Thank you for pressing play on our presentation on the introduction of OMERACT methodology of composites. We're excited to have Dr. Dorcas Beaton and Dr. George Wells, members of our OMERACT Executive Committee and co-chairs of our Technical Advisory Group, present today. They will provide an overview of the concepts and terms used for composites at OMERACT and foster an understanding of the key elements in the development and testing of composites. This video assumes the viewer is familiar with the OMERACT way for domain and instrument selection and has watched those whiteboard videos. If you are new to OMERACT and haven't yet seen those videos, please press pause on this and follow the links below to the 2 whiteboard videos. You can also find additional resources on our website at www.omeract.org.
Composite outcomes are a widely used technique to combine outcomes or domains of interest. The OMERACT Technical Advisory Group, or TAG, recognizes this need within the workings of OMERACT. This presentation is intended to introduce composites at OMERACT. The aims are twofold. First, to reach an understanding of the concepts and terms used for composites at OMERACT, and second, to understand key elements in the development and testing of composites. Why do we need a composite? For a patient, the disease impact and response may not just be for one thing, but actually a combination of things. It may not just be for pain intensity or stiffness or radiographic change or cognitive fog, but rather a combination of these domains. A composite does this by bringing together scores on each domain into a single composite score. Sounds great, and conceptually it should work well in a field such as arthritis, where a spectrum of domains is of interest. But we need to take care to make sure that we have balanced all the different elements to get a meaningful score. Today we will go through what we believe are the 4 steps involved in creating a good composite. First, choosing the relevant domains. Second, getting a high-quality instrument for each domain. Third, deciding on a scoring approach. And finally, putting the composite through filter 2.1. We will go through these steps one at a time using CDI as an exemplar. The Clinical Disease Activity Index, or CDI, is an example of a composite. The CDI is composed of 4 domains: tender joints, swollen joints, patient global, and provider global. An example of the scoring for a patient is given in red for each domain, and then the CDI score is the simple sum of the domain scores. For interpretation, the CDI is referred to a categorical ranking label. In this example, the CDI total score is 31.5 and falls in the top category with the label of high activity. The first step in our creating composites is choosing the relevant domains. This choice involves, first, knowledge of the target phenomena under consideration, whether it be, for example, disease activity or flare. Then to generate and decide on the relevant content that captures that phenomena, checking the literature, accepted approaches, and finally getting agreement on the relevant content. For CDI, these relevant domains were joint tenderness, swollen joints, patient global sense of disease activity, and provider global sense of disease activity. The next step in creating composites is identifying high-quality instruments for each domain. So each domain needs an instrument to measure it. The choice is important. We want high-quality instruments to reduce error and make sure we are measuring each domain well. Returning to the CDI example, the choice of the instruments include joint tenderness, the 28 joint count, the swollen joints, the 28 swollen joint count, the patient global sense of disease activity, a global scale from 0 to 10, and the provider global sense of disease activity, a global scale of 0 to 10. The overall score then ranges from 0 to 76. The next step in creating composites is to decide on the scoring system approach. There are several weighting schemes and several approaches to determine the weights, some leading to continuous scores and other to binary scores. For the CDI instrument, each instrument is scored. Again, for the patient example, the scores are given in red. Note we have not put in the total score since this depends on how we would weight the score for each domain. For CDI, the simple weighting scheme of equal weights, as indicated by 1, was used to combine the domain scores. The authors of CDI have selected this equal weighting system, but in general it doesn't have to be. If deemed appropriate, they could have used different weights for each domain depending on the importance of the domain. For each domain, the patient's score for that domain is multiplied by the corresponding weight. Adding the weighted score yields the total score of 31.5. As we did before, this continuous score can then be referred to the CDI score thresholds, yielding a category outcome with interpretation. In this case, the CDI score 31.5 is in the 4th category and is given the label high activity. Let us consider in greater detail weighting in composite scores. Domains in every composite are weighted, even if that weight is 1. The choice of the weights should be clear and well thought through. To illustrate some decisions on weighting, 2 examples are provided. The first is from cardiology, a medical discipline with a long history of using composite outcomes. The second is a well-known composite in rheumatoid arthritis that was the focus of the first OMERACT over 2 decades ago. Example 1 is an illustration of a binary composite. The composite consists of 3 domains, as given in the first column: myocardial infarction, medications for congestive heart failure, hospitalization for congestive heart failure. The instrument for each domain is a simple yes or no, as indicated in the second column. The patient example, given in red, indicates that the patient did not have a recurrent MI because of the 0, but did have medications for congestive heart failure and hospitalization, as given by 1. In column 4, an equal weighting system was used, as indicated by weights of 1, and the weighted scores were determined, being 0 or 1. The weighted scores are summed, and if a non-zero sum is found, in this case 2, then the composite outcome is considered to have occurred, as indicated by yes. One concern with this composite is all domains were given equal importance, as indicated by 1, the weight, in column 4. An exercise was conducted in 2017 to identify weights that reflected the relative severity of each of these domains. This led to weights of 0.5 for recurrent MI, a weight of 0.2 for congestive heart failure medications, a weight of 0.5 for hospitalization for congestive heart failures. And now the weighted scores led to a composite of 0.7. For domains of different importance, such an equal weighting system can be used. The ACR 20 provides a different way for considering a weighted composite score. Recall that the ACR 20 is a binary outcome with yes if there is a 20% improvement in tender joint counts, and a 20% improvement in swollen joint counts, and a 20% improvement in at least 3 of the following 5 domains: acute phase reactant, given by CRP or ESR, patient global assessment, physician global assessment, pain assessment, or disability functional questionnaire. Here is an example of a patient score on the ACR 20. This is taken from the ACR Committee to Reevaluate Improvement Criteria. In the first column, we have our domains: tender joint count, swollen joint count, pain, patient global, physician global, health assessment questionnaire, and C-reactive protein. In the second column is the range of the scores for the instruments of each of these domains. In the third column, the score for the patient in pretreatment is given. In the fourth column, the final value for the patient is given. And in the fifth column, the percent change is provided. So for example, for tender joint count, there we found a 67% improvement in tender joint counts. However, for swollen joint count, there was actually a decrease of minus 16%. And so this patient did not reach the threshold for ACR 20. In terms of our steps, the domains of this composite are tender joint count, swollen joint count, acute phase reactant, patient global assessment, physician global assessment, pain assessment, and physical function. The corresponding choice of instruments are the 68 tender joint count with an improvement of greater than or equal 20% yielding yes, a 66 swollen joint count with improvement of greater than or equal 20% being yes, the CRP or ESR with improvement of 20% or more providing yes, and then we have a VSR or numeric rating scale of 0 to 10 for either the patient global, physician global, or the pain assessment. And if an improvement is seen of greater than or equal 20%, it will receive a yes. And physical function is given by the HAQ-DI. Again, improvement of greater than or equal 20% will be yes. An example for a patient given in red is that this patient received yes on tender joint count and yes on swollen joint count. Received no, not reaching the 20% improvement for acute phase reactant. Yes on patient global assessment. Yes on physician global assessment. No on pain assessment. And the physical functioning received the yes. The weights for this, if you have a tender joint count and the weight is given as 1, the swollen joint count, the weight is given as 1. For the other 5 domains are considered as a group, and at least 3 of the 5 have to receive a yes, okay, in order to get a weight of 1. All 3 of these weights, okay, need to be 1, indicating a yes for the ACR 20. In our patient example, they did get the tender joint count, they did achieve the swollen joint count, and they reached 3 of the 5 other assessments of the domains. And so we have a yes, yes, yes. The overall is a yes, and the ACR 20 was achieved. How can a weighting scheme which considers different weights for the domains be determined? Okay, first, composite outcomes have been criticized for pooling domains of varying clinical importance or being driven by clinically less important domains which are observed more frequently and earlier. A solution is weighting domains to improve the clinical relevance and the interpretation of composites. Several approaches for this weighting are available. In the gray box, 4 are indicated. In the first, a discrete choice experiment involving patients determined relative important weights for the different composites, for the different domains within the composite. The clinician investigator approach was using Delphi panels to determine these relative weights. An economic approach was used in the third one for looking at disability-adjusted life years for determining these weights. And then finally, an analytic approach using flexible weight constraints is the fourth example. We have now derived our composite. We have chosen the relevant domains. We have identified high-quality instruments for each domain. We have determined a scoring system approach. And now we have the composite. The next step is for the composite to go through filter 2.1. And for that, I'll pass it over to my colleague Dorcas to discuss that. Thank you.
Now we will move through the final step of moving that composite through the OMERACT filter. So just like we've done with other instruments like a pain scale or a measure of physical functioning, we now need to check out the composite to see if the resulting score can represent the target concept that we were after. Disease activity, for example, or a response. Is the score detecting this response accurately? Does it correlate with other indicators of a related target concept? Does the composite score change when it's supposed to change, when we can be pretty certain that the target concept, like disease activity, has actually changed as well? The evidence we gather should also be considered in the light of the way that the composite is going to be used, the context of use. Who are the target patients, for example? Will they all have high levels of disease activity, or moderate or low? We need the validity evidence to be gathered in a similar situation to the intended use. We still look for the same type of filter evidence of feasibility, truth, and discrimination in the applied composite. Having good instruments make up the parts of the composite does not guarantee that the compilation of those parts into a composite will pass the filter. So put the whole composite through the filter. All parts of the OMERACT filter instrument selection algorithm, or OFISA as we know it, still apply, as will the guidance in the handbook about the measurement properties that you need to be looking at. And ultimately, what this is about is our ability to be able to trust the scores that we get from a composite. It's sometimes a bit more challenging because the composite is bringing together so many different domains into one score. But on the other hand, it's often bringing together information that makes a lot of clinical sense. But our goal is trusting the scores. So thank you very much, and we hope that this helps you understand a little bit about composite measures at OMERACT and the types of things that need to be considered when looking at developing a new composite or using an existing one. George and I would like to just acknowledge the people that are listed here for their help in working through the implications of moving a composite through the filter. And we wish everyone good luck with your composites.